Welcome to AETCM, the Emergency Medicine channel. Myself, Dr. Naveen Mohan, HOD of Emergency Medicine at AIMS Kochi.
My name is Dr. Jaren Anthony, Emergency Medicine first year resident.
I am Dr. Cecil, first year resident, Emergency Medicine.
I am Dr. Evin, first year Emergency Medicine resident.
Start.
50-year-old male patient and came to our ER with alleged history of accidental ingestion of turpentine yesterday at 1 p.m. followed by he arrived at our ER within 1 hour. On initial 10-second assessment, patient was conscious and oriented. On going to primary survey, airway was patent.
Then you are all prepared with your preparation is important in here. Do the preparation. That's a poisoning case. You don't know whether it's an OP or it's a mixed. So you should be ready with your PPE, everything. Because you yourself shouldn't be
personal protection.
Personal protection, PPE. Okay, and all other things should be ready. This is at least the history of turpentine oil consumption as per the bystander.
Patient
placed one day back.
No, sir.
How many days back?
Yesterday was this event happened, and within 1 hour, patient came to ER.
Okay, go ahead.
And going to primary survey, airway was patent. There is smell of aromatic smell is present, likely to turpentine. On breathing part, respiratory rate is 26 per minute. Saturation 92% on room air. On chest examination, bilateral V's was present. Within
why did you bypass? Why didn't you do inspection palpation and
on inspection, chest is symmetrically rising. There is no any asymmetry of chest expansion. Palpation.
Both the same rate, symmetrically rising. No need to say the same thing again and again. You told it's equally rising.
Okay. Palpation part. There is no any tenderness, no any subcutaneous emphysema, normal, sir. On auscultation part, on chest there is bilateral V's is there. On percussion part it was normal resonant sound. Then
what is the respiratory rate?
26.
So it's a bit on the higher side.
Saturation is 92 on room air. So that's why we started with face mask with 4 liter O2 and along with we will start devolving salbutamol nebulization also.
Why did you start the face mask? Why not nasal prongs?
We can start with nasal prongs, then we can check for some time. Then if the saturation is not increasing, we can move it on face mask.
Like beyond what? What is when will you use a face mask?
If we started on nasal prongs, then up to 4 liter we can give on nasal prongs, but the saturation was not maintaining up to 95%. Then we can change to face mask.
So beyond 4 liters, you will be switching to
face mask.
Face mask and NRBM.
From 8 to more than 10 we can start. Up to 8 face mask we can give. To 8 to 10 we can give by humidified.
So how much of FiO2 you will get in each thing?
Every 1 liter increase there is 3.4 into 21%. Normal 21% is the
21% is the normal room air. So FiO2 will be 0.21, right? FiO2 point.
Every 1 liter rise in there is
21%. Every 1 liter, how much FiO2?
3.4 into 21%.
Into 21.
21% plus 3.
In mask, what is the maximum FiO2 achievable? Face mask.
Face mask maximum is 10 into 3, 50, maximum 50 to 60%. 40 to 50%.
Right,
40 to 50% maximum we can.
Okay. And NRBM?
NRBM maximum 80 to 100% we can give.
FiO2 will achieve. Okay. So for this you kept nasal prongs.
Nasal prong.
Face mask.
We kept. We can.
And nasal prongs would have been sufficient.
Then going to circulation, heart rate was 96 per minute and BP was 130/90 millimeter mercury, and CRT is less than 2 seconds. And going to disability, GCS was full 15/15 and pupils 2.5 bilateral equally reactive to light.
Heart sounds and all you examined?
No, heart sounds are normal, sir. As soon as to GRBS
But
is
you play cannula, you don't place a cannula at that point, no?
to normal cannula, 20s cannula you can put, and we can take the blood investigations and for toxicology or anything. Routine investigation. Routine investigation.
What all?
In by patient history, turpentine poisoning, it is not able to.
History, you just got a history that turpentine.
Turpentine.
You will take a detailed history. Detailed history you will be taking only in secondary survey.
Secondary survey. Then
This one is just somebody, some bystander told he took turpentine. That's all you know. You have
patient told it is
now you are
turpentine.
stabilizing. You are doing a primary survey and stabilizing it. So you are still in C. You have to draw blood samples for all hematology, ABG, biochemistry, blood gases, everything you sent. Okay.
In airway there is a smell of some alcohol or aromatic.
That you already told. No?
So that's why we can suspect any co-injection. We can send serum alcohol level by sending.
No, that's not in primary survey. Primary survey, you are stabilizing the thing. We are not going to
Routine investigation.
find out what he consumed. We want to stabilize the entire ABCD. What is the cause of the thing and all should be dealt after stabilizing. Suppose in between it goes into cardiac arrest, what will happen? You keep on smelling is this thing alcohol, immediately some arrhythmia happened, he get arrest. Then there is no point in smelling alcohol. Okay, you are still in C, placed a cannula.
Cannula. Then disability was GCS full. People
Blood samples all drawn. ABG,
drawn.
ECG.
ECG.
Because in all suspected cases, in any poisoning case, any poisoning case means somebody can die only if the CVS or there should be cardiac or a respiratory arrest. Otherwise, nobody can die. So at that point itself, you take an ECG. You don't know whether this solution is mixed with some tricyclic antidepressant. Because if there is a TCA overdose, naturally that will be reflecting some ECG changes will be there. Okay, so ABG should be taken immediately. Draw blood samples for ABG immediately as seen C. All routine blood tests, including toxicology, you can send at that point of time. Then take an ECG. I don't know. Then
in exposure temp, GRBS is 96 and exposure temp.
ECG was normal.
Normal sinus rhythm, sir. There is no any arrhythmias.
So until and unless CVS or RS is affected, patient won't die. So that is the thing. Okay. So that is your priority first. Any poisoning. Okay. Either A, B, C, D, E. A kills before B, B kills before C. Like that. Okay. Go ahead.
Okay. On exposure part, temperature was normal. Then
disability.
Disability was GCS full, sir. GCS full. People's 2.5 millimeter bilaterally equally reactive to light. GRBS was 96 milligram per deciliter.
Any lateralizing signs?
No, sir. No lateralizing sign. People's are equally reactive. Size also normal. Then exposure temperature was normal. Then coming to an adjunct to primary survey.
Then this is a poisoning case. No, not only temperature. The skin has to be examined completely. Whether it is a hot, flushed skin or whether it is sweating is a suggestion of OP poisoning. Whether it is anticholinergic or cholinergic. You got to know. Whether it is cyanosed. Certain poisons will cause cyanosis. So certain things will cause slate colored this thing. So you'll have to document all these things.
Remove the contaminated food dress. Remove the contaminated dress.
If it was
for
something there,
medical legal purpose, we can collect it for.
That we can remove, but skin has to be examined perfectly.
And irrigate the skin and.
Not for this case. If there is profuse secretion and all, your diagnosis altogether will change. Because at least history of kerosene, turpentine, this thing will not cause
Skin
profuse
flushing,
secretion.
sweating.
Then it's probably it's mixed with some organophosphate. You'll have to see for some fasciculations, the muscular fasciculations, seizure kind of things and all. Okay. Because right now you just know that some random person came and told you it's turpentine. So it doesn't mean that it is turpentine. Okay. And the patient also told you probably.
Patient is told.
All right.
Then coming to adjuncts to primary survey, taken an APG, APG showing pH was 7.36, PCO2 42, and PO2 is 80, and bicarbonate is 23. The electrolytes was normal in APG. Then that time we take an ECG. ECG was showing normal sinus.
Methemoglobin and all. ABG will get methemoglobin also, right? Methemoglobinemia, their levels. Carbon monoxide. This thing. If there is a co-oximeter and all, you can check for carbon
monoxide level.
Co-oximetry. Carbon monoxide levels. Okay. Electrolytes were all fine. ABG is fine. ECG is fine. It's A, B, C, D, E. Everything is fine. So
clinically, there is patient had decent hypoxia, not hypoxia, like saturation is 92. Wheeze was there and is saturation 92% room air.
Already kept on oxygen
And nebulization.
Okay. So at the end of primary survey, this is a very stable case.
Stable case.
That is very stable case. Okay, he can actually be in the which area? Green area, red area?
Green area.
Green or yellow? O2 monitoring is required, no? Not that
stable.
O2 is required. So it shouldn't be it should be in the yellow area.
Yellow area.
Okay.
Then coming to the sample history, secondary survey sample history. 50-year-old male patient, known case of diabetic, no any allergic history.
No, that is okay. You're taking to go in that way. Okay.
Allergic history. Has taken non-diabetic on OHS. Patient had last meal on 10 a.m. Then at around 1 p.m. while painting his home gate, he has accidentally taken the turpentine. He thought it is water because it was stored in a soft drink bottle. So he accidentally thought it was water and he's taken one mouthful of turpentine. Then he knows that it was.
How did he know that it was turpentine?
After taking inside, it was a smell and the sour taste is there. So that's why he understand it was turpentine. He already kept there. Water bottle and turpentine kept there for painting his gate.
Okay. You already knew that
it was turpentine, but it was not in a turpentine bottle. It was a soft drink bottle.
Accidentally.
He
himself only kept and he himself drank.
Followed by within 20 minutes, patient developed abdominal discomfort and multiple episode of vomiting. And there is no history of any.
So this is an event. So you have got three approaches while taking an emergency medicine case. One is if the patient his main complaint is pain, you go ahead with the Socrates approach. That means site, onset, character, radiation, associated symptoms, timing, exacerbating relieving factors, and severity. Whereas if you are dealing with not pain, if it is about like breathlessness, you go ahead with the OD para approach. That means the onset, duration, intensity, progression, previous episodes, aggravating relieving factors, associated symptoms. And if it is an event like this, if it is an event like at least history of consumption of the poison, or if it is a accident case, road traffic accident, or if it is a collapse, you go ahead with the WHO approach. That means it's a big event. You'll be normally asking where it happened, who saw the event. It's WHO approach. Where it happened, who saw the when it happened, who saw the event, what happened before,
Before
the event,
then.
what happened
After
during the event,
then,
what happened after the event, how long this event lasted, what was done by the onlookers. I don't know. So everything surrounding that event should be mentioned clearly. So this is a alleged history of consumption of turpentine oil, accidental consumption of one mouthful of turpentine oil by the patient himself, and he already knew that like it's a misunderstanding. Like he kept the turpentine in that bottle, and he drank it. Okay, and what was done? What was done after that?
followed by with
He spit this thing.
that's it. Followed by then it spits out. Within 20 minutes, patient developed abdominal discomfort, vomiting, cough.
That is right later on. Follow that. What happened in the first 20 minutes? You just bypassed the first 20 minutes.
You find irritation in our oral area and oropharyngeal area. Then it becomes abdominal
Did he
discomfort.
drink the fluid completely or partially?
Partially is drink. Partially drank.
One mouthful. So
Partially is-
he drank and he understood.
Understood, yes.
And he spit it.
Taste and smell.
Then what did he? Some sort of taste was there.
Taste, sir. Then there is erosion over the oral area, oral pharyngeal area erosion is there. Like irritation is not erosion, irritation.
He told like that.
I told like that.
Then what did he do?
Then he tried to vomit by putting his finger inside his mouth.
He vomited or?
Then after 20 minutes, patient had abdominal discomfort and he vomited.
After 20 minutes.
20 minutes.
So what about the first 20 minutes?
First 20 minutes, he tried to vomit, but he only nauseated. There is no vomit coming. Then he drank approximately 1 liter of normal water.
Okay.
To mix it with, he thought like
he
that.
dilute the thing.
He drank approximately 1 bottle of water, 1 liter. Then within 20 minutes, abdominal discomfort and he had vomited. Followed by he had
After 20 minutes, had the abdominal discomfort and
vomited. Then he had feeling severe cough without
What did he
any.
vomit?
Sir.
What did he vomit?
Vomiters contain food particles, sir. Morning food particles. He had taken morning meal at 10 a.m. That food particles he vomited. Then he is told that there is no any blood stain, but there is continuously the smell of turpentine is coming through his oral area. While we talking with him also, while he breathing out, there is smell of turpentine will be there.
Okay.
Then he feeling belching and bloating and abdominal discomfort continuously. Vomitation. Then there is a dry cough. Without any expectation, patient had dry cough followed by this event. No history of any breathlessness. No history of any flushing, sweating.
After completing this OD para, you address all the other 8 systems of your body. Address, like, say the negative history about each system. So because he consumed this thing, first of all you address the GIT complete this thing. The negative history pertaining to GIT. So what are GIT and genitourinary combined you can take. What are the 8 systems? GIT, genitourinary, serious RS, CNS, musculoskeletal, skin, miscellaneous. And then probably you can, CNS you can include ENT things also. Okay, so GIT,
vomiting, abdominal discomfort, belching, bloating, no history of loose stool, no history of like fresh hematochezia, no history of blood in vomiting. Stool is normal. Already it was not past stool is after 1 day. Acutely there is no any hematochezia.
Past stool.
Yeah. No history of loose stool. Then
abdominal pain.
Abdominal pain is there. Abdominal discomfort is there. No history of abdominal pain. Then going to
After that, this thing, after 20 minutes he vomited, and immediately after that, did he go to some other hospital?
No, sir. Directly came to here because he is our.
You told it happened same day, sir.
Same day. Yesterday this case happened.
Yesterday this case
happened.
And he went to some other hospital, or?
No, sir. Yesterday 1 p.m. it
After 24
happened.
hours only he came to.
No, sir. Within 1 hour, patient came to our here. We are presenting this case on today only. Like yesterday, this case happened.
Okay. Within 1 hour he presented.
He is our staff of our hospital, so directly he came to. So followed by GAT, patient had cough, so we goes into respiratory system. There is dry cough is there.
Genital urinary all clean, right?
GAT urinary was fine, sir.
No negative.
No,
Urination, everything is fine.
normal, sir.
Okay. Urine color is everything is fine.
Normal, sir.
Okay.
Then going to respiratory system, cough was there, which is dry cough. There is no any breathless, not associated with any breathlessness, no hemoptysis.
Is there?
Wheezing is there. Then
The wheezing means it could be because of an organophosphate poisoning. Wheezing is there. No? Wheezing will be there, right? In OP poisoning.
Krebs and bronchoria will be there in OP poisoning.
You should think about that also.
Yes, sir. But there is no other like
Other things are,
other things are negative, supported diagnosis.
Okay, then.
Then going into CVS, there is no any palpitation history, no history of syncope, chest pain,
Dizziness.
syncope, nothing is there. Palpitation,
Palpitation.
palpitation, nothing is there. Then going to CNS, there is no history of any altered sensorium. Patient is fully conscious. On skin also, there is no any
Interesting. Seizure.
and also seizure.
Because all these poisons will cause seizure, fasciculation,
rigidity,
jerks,
mild jerks,
agitation, altered behavior,
weakness.
weakness. You don't know whether it's clearly turpentine. So you'll have to ask questions for all questions pertaining to
All systems.
systems, because all these problematic poisons usually will affect the CNS, CVS or the RS, and then GIT will also be. Also CVS detailed history has to be taken.
Then coming to other skin area, there is no any exposure to skin area.
CNS and musculoskeletal together.
No rigidity, no fasciculation, no
Body
weakness.
pain, any body pain, muscle pain,
No, sir.
weakness, paralysis,
No,
any trauma? No.
no, sir.
Okay.
Then skin wise, there is no any contact. Basically, hydrocarbons, if there is in contact with skin, causes skin irritations, and mucosal membrane also causes irritation. So patient here, oral and oropharyngeal irritation is there, but skin wise there is no any irritation is there. Then all system covered.
Any fever or no?
No, sir, no. Okay, then patient came to
This is about your complete HOPC. Presenting complaint.
then patient presented to our ER within 1 hour.
Then past history.
Past history wise, in a known case of diabetic on OHS. Then
Medical history, surgical history.
is no any surgical history. Medical history was on OHS, no allergic history, and last meal was taken on 10 a.m. And event was the same. Then coming to
Any similar history in the past? Any psychiatric history?
psychiatric history, no sir, no any history of any axle injection.
Similar history of because we don't know whether he's telling the truth.
Truth.
Suppose he's a psychiatric patient, or he has got some other depressive disorder in which he has a general tendency to harm himself. Then that has to be taken. Okay, family history and all, it's not relevant here because it's a poisoning case, and turpentine, he was doing some paint work or something of that sort. Okay. And he's completely stable also.
No.
So, there is nothing much to discuss in this case. Turpentine, well, there is just supportive care is all what's needed. Just take care of the airway, breathing circulation, supportive care. That's all.
For patient presented with in this patient desaturation and chest findings is there, then we will this patient will require admission for 24 hours.
And what about the Chest examination.
Chest examine wise,
Stabilization.
chest examination by after nebulizer also V's will be there. It will improve the chest findings only, but V's will be the V's is there. So we admitted the patient for 24-hour observation. Like up to date approach, like we can discharge the patient.
Can it be anaphylaxis? The V's. V's. Why would? Can it be anaphylaxis also? That's also possible. Accidental consumption of something followed by involvement of B. Breathing. That is also a
Possibility. Then we observe by to look on any cardiac arrhythmia, so cardiac monitoring is needed. Then we will symptomatic management is the based 24 hours, and we
you'll anyway require admission because the oxygen saturation is less. PO2 is a bit
lower side.
low, so we'll require admission. Methemoglobin, everything is okay. X-ray, chest X-ray.
Chest X-ray, increased bronchial marking is there. There is no any infiltrate, but increased bronchial markings.
If you're suspecting some aspiration pneumonia, you can start on some antibiotic. Also.
And basically, according to in up-to-date the algorithm is telling if after 48 hours, if there is any leukocytosis or fever, we start with prophylaxis and chest findings. We can start on prophylactic antibiotic. Then if there is no any breathlessness and no chest finding, X-ray was normal, no ECG findings, only accidental intake of turpentine, but patient symptomatically and clinically okay, we can observe for 6 hours. After 6 hours, we can take a chest X-ray to look for any chest infiltrates. Then it was normal, we can send the patient, like OPD basis, we can send the patient. In this patient needs admission at least 24 hours, and we can work upon the routine lab, and we can wait for any fever spikes or repeat X-ray after 24 hours. If there is anything finding is there, we can diagnose as chemical pneumonitis.
Chemical pneumonitis. So that is the complication that you're expecting.
Chemical pneumonitis, and in hydrocarbons, the turpentine mainly came to in a group of hydrocarbons, so that will causes catecholamine stimulation causes arrhythmias. So ventricular arrhythmias is more common. So cardiac 24-hour cardiac monitoring is needed, and it will causes activation of NMDA and GABA receptors. So seizures also is a complication, and chemical pneumonitis is the main complication.
Is there an indication of gastric lavage in this case?
Gastric.
The patient had come to you within 1 hour of consumption.
In hydrocarbons, gastric lavage and activated charcoal is contraindicated because of
Activated
the
charcoal is also
contraindicated because activated charcoal contraindicated because of it has no property to absorb the hydrocarbons. So when gastric lavage will be causes where continuous stimulation and aspirating fluid, it will causes chance for aspiration, again chance for chemical pneumonitis. So better to avoid gastric lavage in hydrocarbons.
In all cases, activated charcoal is contraindicated. In all cases, gastric lavage is contraindicated.
Contraindicated like corrosive poisoning like acid alkali poisoning and metal poisoning. Acid and alkali corrosive poisoning is gastric lavage is contraindicated, and hydrocarbons, petroleum products,
Gastric lavage
and
or activated charcoal.
both are contraindicated
In hydrocarbons, volatile poisons, and in corrosives, both gastric lavage and activated charcoal is contraindicated. And activated charcoal is not effective in this hydrocarbons. And then heavy metal poisoning, lead iron, heavy metal poisoning, and inorganic salts like sodium chloride is not effective.
And what other this thing gastric lavage contraindicated, other things?
patient if patient reaching low GCS and sensory was not, patient is not able to maintain his airway, it is contraindicated. So in this kind of patients, we can maintain the airway. We can mechanically ventilate the patient and we can use gastric lavage.
Use a definitive airway if at all the patient is drowsy, so his airway is protected, and then you can do a
We can give gastric lavage or activated charcoal also. Then if the patient is reaching our ER after 2 hours, also it was no use in giving gastric lavage or activated charcoal. And these are the contraindications.
There is the consumption is of some, like if there is a delay in gastric emptying,
Sustained relays substance we can use that.
there is a delay in gastric emptying and things like that. And another thing is if there is some intestinal obstructive features of that, if there is any perforation which has happened because of the corrosive, then also gastric lavage and all these things will be
Contraindicated.
contraindicated.
Activated charcoal we can give dose of 1 gram per kg. Ideally adults we can give up to 50 grams. We can take it is available as a powder. So we can mix it with the distilled water and make it to a slurry. Then we can give through the orogastric tube. That's why how it's giving.
What about gastric lavage? How it is done?
Gastric lavage by inserting large bore orogastric tube and continuous instillation and aspiration the
How, in what position and
45 degree
Gastric lavage is done in a propped up position to prevent aspiration, and large bore RT in
orogastric?
orogastric
RT is very narrow.
narrow orogastric tube, 28 or 32 or can be used the front size, and then continuous infusion is given through that orogastric tube, and then continuous aspiration is done. It is a painful procedure.
Till when, like when what is the end point? Till when you will?
till it is clear.
Till it is clear. No?
And while doing gastric lavage, you will send the sample for toxicology. Is very important to look for.
Any thoughts about whole bowel irrigation?
Whole bowel irrigation.
Peg leg. You know about peg leg?
Oh.
2
To
liter
remove
per hour
the,
you can give. If it is beyond, it has crossed the stomach.
Small intestine we can.
Then you can give a bowel irrigation 2 liter per minute. Especially in gastro, like if for
Colonoscopy.
colon preparation, and you will give
Peg leg.
So this one you can give 2 liter per hour peg leg. And until the rectal effluent is clear, you can keep on giving. Okay. So these are all this is will work only if the absorption is very delayed absorption kind of things. If it's a very quick absorption, within 1 hour it gets absorbed, then there's no point giving whole bowel irrigation. If it is a delayed absorption, toxin is a delayed absorption toxin, then you can try these things. Nothing more. So basically it's a supportive care, hydrocarbon. Take care of the airway, ABC, and just wait and watch. C for associated. C for deterioration or any deterioration in clinical status, and treat accordingly. Okay.
Thank you, sir.